From 2016 to 2017, there was a 46% increase in opioid-related fatalities within the province of Ontario. Nationwide, Buprenorphine Naloxone, otherwise known as Suboxone, is recognized as an ideal first-line agent relative to methadone, as there are numerous medical benefits and fewer regulatory prescription barriers. However, numerous physicians are reluctant to use this medication as there is a risk of precipitated withdrawal associated with traditional induction techniques. Additionally, many patients voice concerns related to the requirement to be in a state of withdrawal prior to initiating treatment with Suboxone. In order to circumvent these concerns, a method known as the Bernice method or microdosing has been proposed. The Bernice method uses a slowest possible introduction of Suboxone onto opioid receptors and facilitates a gentle loading of the high binding affinity and long half-life Suboxone without significant displacement of the full agonist opioid. In other words, this method is a novel technique that helps to circumvent the risk of precipitated withdrawal when starting patients on this treatment. Our study, which to our knowledge is the largest of its kind, aims to further elaborate and propose additional factors that may predict successful conversion and continuation of buprenorphine. To our knowledge as well, there have been no randomized control trials that have been done related to this topic, and the entirety of literature is limited to case studies and case reviews. In order to complete this study, we analyzed 26 individuals living in Ontario who had simultaneous prescriptions for methadone and Suboxone. We completed a retrospective cross-sectional study as well as descriptive statistical analysis. 2 cohorts of patients were analyzed, one of which remained in treatment with buprenorphine, the other who discontinued treatment. The results of our study have been summarized and are able to be viewed in Table 1. As you can see, over half the patients that were included in the study remained on treatment with Suboxone. Numerous risk factors have been described in Table 2. One of particular interest, however, has been highlighted, which is that buprenorphine naloxone titrated over a period of 7 days or longer was associated with an increased risk of success with microdosing. There is some disagreement about this in the literature, as a different study published in 2019 described a rapid induction protocol for inpatients that started patients at higher doses more frequently, such as every 4 hours, and successfully titrated their buprenorphine naloxone over a period of 3 to 5 days. Our study, which was actually completed on an outpatient basis, suggests that starting patients at a lower dose and titrating over a longer period of time, such as 7 days or longer, is associated with a higher likelihood of treatment retention. Generally, rapid microdosing would be preferred in an inpatient setting, as prolonged courses of titration may result in incomplete induction or delayed discharge. Overall, we would recommend that both rapid and inpatient and outpatient microdosing protocols be evaluated in order to examine the efficacy and safety of both of these procedures in diverse patient populations. As this study was a cross-sectional study, the results only paint a point-in-time picture and therefore must be analyzed within this context. Furthermore, since there is a great degree of variety between different OAT programs, the results from our study may only be generalizable to patients who attended an outpatient treatment or OAT program with similar programming. In addition, we recommend that future studies aim to systematically review the Bernice method in order to determine whether or not it is actually associated with improved tolerability compared to conventional induction techniques.